be doing the introductions for today's grand rounds because Dr. Barbara Stewart is not here today, so I'm filling in her place. And I have the pleasure and honor to introduce my colleague, Dr. Sita Patel. She's a licensed clinical psychologist and an associate professor in clinical psychology at Palo Alto University. She completed her doctoral studies in clinical and community psych at University of California, Berkeley, and she completed her pre-doc training at Columbia College of Physicians and Surgeons and post-doc training here at UCSF through the Community Academic Research Training Alliance program. She directs the Culture, Community, and Global Mental Health Research Lab with projects that focus on risk and resiliency, culture and context as they relate to immigration and global mental health. And with that, I'm going to let Dr. Patel.
Hi, everybody. Can you hear me okay? Great. Welcome. Thanks for taking your lunch hour to be with us. It's a pleasure to be here and back at UCSF. As Will said, I did my postdoc here, and I see some familiar faces from Palo Alto here, so very nice to be here with you all. I'm planning to do kind of an overview talk and give you some, hopefully, food for thought for working with your immigrant and refugee patients, and tell you a little bit about some of the outcomes from some recent studies in our lab. Can I just get a show of hands? And I'm sorry for those of you on Zoom, I won't be able to see your hands, but for those of you in the room today, how many of you work with immigrant and refugee families? So maybe a third, okay, or half. Great, just so that I know kind of what the room is. So today my talk is called Understanding and Supporting the Mental Health Needs of Newcomer Immigrant Youth and Families. I don't have any disclosures. I want to start by thanking contributors to the talk. So I'm sharing a whole body of work with you today, much of which is the blood, sweat, and tears of many other people, and I want to recognize them. Will Martinez is here in the room. Nick Nelson is over at Highland Hospital. He and I have been on the Grand Round circuit together. He wasn't available today, but we've given a similar talk together. And Alfonso Mercado is down in Texas doing really interesting border work that I'll talk about at the very end. Holly, Maggie, and Mercedes are 3 students in my labs, and I'll be talking a little bit about some of their projects as well. Okay, so my objectives for today are to increase your knowledge about complex risk factors faced by immigrant youth, in particular those who arrive unaccompanied by adults and those who are somewhere in the asylum seeking process. And I'll talk a little bit about some sort of socio-political contextual factors. I'd like to explain my current research to you, and again, as I said, just some quick kind of outcomes of various studies that we've done in the lab. And then I'm going to leave you with some tools and resources that you might think about incorporating into your own practice. Okay, and we'll hopefully have some time at the end for questions. All right, so let me introduce my group. This is the Culture, Community, and Global Mental Health Lab. We are down at Palo Alto University. This was our sunny and happy annual brunch. We're more often in the trenches in schools and clinics and hospitals doing frontlines work. These are all doctoral students training to be licensed clinical psychologists. So our work, as I mentioned earlier, covers risk and resiliency, mostly among adolescent immigrants who are newcomers, so recently arrived. Some of them have arrived within the past few weeks, others within a year or two, but really in those early stages of acculturation. We believe very strongly in community partnership work, so really building a program of research and trying to do research and ask questions that are highly relevant and kind of urgent for the communities that we partner with. We do work with clinics focused on refugee mental health, in particular those who are survivors of torture. That's more adult work. I won't be talking as much about that today. And then we have some international projects in sub-Saharan Africa, trauma healing projects. So I'm going to focus today on the first 2 of those bullets. And I want us to just start with this idea. So it's kind of a dialectic that immigration has always been part of what we'll call the United States. Of course, before it was the United States, immigration was not relevant, but since we've been called the United States, we've always had some aspect of immigration. So we're really a nation built on and founded by immigrants. And yet, today really is a unique context and a unique time. So I'd like us to go into this talk kind of holding both of those in our mind, that there's both a timeless aspect to immigration. I'm sure most people in this room have some kind of narrative, either for themselves directly or somewhere back in their families, of immigration history. And yet we're living in a time when it's really much more part of the heated national debate than it maybe ever has been, but certainly that has ebbed and flowed over time. So this is kind of an ebb and flow image. I like this. One, it's pretty. And two, it kind of gives you a sense of how different waves of immigrants have come over time. So in case those numbers are too small for you to see, starting at the bottom left, that's 1829. And we can see some of the bands in the early part of the 20th century. There was a peak, and a lot of the countries that were sending immigrants to the United States were countries like Russia, Germany, Austria, Hungary. Then there was really a waning of immigrants being received in the United States around the Great Depression. So not surprisingly, these socioeconomic forces that really play a big role in who's being allowed into the country and why, and a lot of those policy decisions. And then now, so it ends at 2015, and we can see there's really been a huge influx in the numbers of immigrants coming, and largely from Latin America, the Caribbean, and those regions of the world. So there are a lot of clinical implications to immigrant status. And so, we use the word immigrant, but really that's a pretty broad catch-all term. And there are a lot of complicated designations that your patients may or may not have as part of their immigrant status that may play a pretty big role in their lives and in what enabled them to get through the door to be a patient of yours, or barriers that kept them perhaps for a long time. So here are some of the terms that are useful for you all to know. Just briefly, so an immigrant is somebody who comes to live permanently in a new country. An undocumented immigrant is somebody who comes without the legal documentation. So we're of course reading a lot about that these days in the news. Unaccompanied minors, so these are a large portion of the kids in our studies are unaccompanied minors. So they're people who are arriving at the border or into the country without an adult supervision. So sometimes they come completely alone, sometimes they come in groups, so with a sibling or perhaps a slightly older cousin, but without a real guardian. DACA is the Deferred Action for Childhood Arrivals. So these are folks who under Obama were granted a temporary status, protection from deportation. That of course has been under threat recently. And then refugees, so even within the research on refugees, it's a term that I think is kind of overused, and I think it's useful in implicating folks who have had refugee-like experiences, so people who have fled countries where there have been war or violence or persecution, but really a lot more people who have had those kinds of sort of pre-migration trauma factors are more somewhere in the process of seeking asylum. So refugee is a legal term. Somebody has to have had those experiences and then moved through the system and kind of come out the other end with this designation that gives a certain kind of protection, grants people a lot of access to services and so forth. So we know that worldwide, the folks who are somewhere in that asylum seeking process and are in transit for sometimes many, many years, the numbers of people in those situations are much greater than those who actually arrive in this country and are given refugee status. So even those who have experienced a lot of trauma and have a lot of hardship with that status comes quite a bit of privilege. So just to kind of put in perspective, again, the range of people who you might get through your door as patients. And I like this slide. This is something Nick Nelson spoke about. He's a physician who works over at Highland Hospital, but it kind of gives a sense, and he put some stars here, of where within the process of seeking asylum and getting a refugee status can or may people access the health system. And I think this is super helpful for us to realize that just having that status, you are mandated to have health screenings, you are put into the medical and healthcare system in a way that folks who are asylum seeking really are kept out of. And so you may have people who don't have that legal designation come for services much later and with much more severe situations because they haven't sought services earlier in their sequence of needs. Okay, so we really are operating right now within this context of pretty restrictive immigration policies, and I want us to think about how this rhetoric, how the actual policies, but also the national rhetoric can impact not only families, but the fears that families are feeling are very much trickling down to children. So just having that threat of deportation can generate a lot of anxiety in children. Of course, having a parent detained or deported, there's quite a bit of research now that documents that it really increases children's insecurity, anxiety, and so forth. A lot of mental health correlates to these socio-political circumstances. And sorry, just that last bullet. So I also want us to think about all of these dynamics as operating within a system of multiple complex risk factors. So these hostile immigration policies and practices are absolutely going to play a role in exacerbating the traumatic experiences that kids have had prior to coming here. And so this somewhat overwhelming slide is my effort to kind of relay to you how complex and multifaceted those traumatic experiences may have been. And it's helpful for us to think about them in these different phases. So children who are coming here may have had these pre-migration traumas and stressors, especially those who are coming in that asylum-seeking trajectory. So kids who are in unstable or violent circumstances at home. So there's your list on the left of pre-migration stressors. And then, you know, the kids who we're going to see at San Francisco General who are undocumented youth, especially those from Central America, who I'll talk about in a moment, most likely they didn't get on a plane and come here and arrive with their family. So they most likely had a very long and arduous migration journey. So a lot of the kids in our study who are here in San Francisco public high schools, you know, they spent months getting here, probably by foot, train, bus, many different means. They may have had a dangerous border crossing. They may have been separated during the migration journey from those who they started the journey with. Especially for girls, there are high rates of sexual abuse along the way. So there's a really, you know, lot to unpack when you talk about what was the migration journey like. And then post-migration, and here we're talking about, you know, not only acculturation stressors and just getting used to and adapting to a new environment, but we have a lot of data related to the discrimination experiences that kids are having, the financial stressors that they experience. A lot of the kids we've had in our studies, you know, they're not only they, but their parents and siblings are all, you know, working 24 hours a day between all of them to try to make ends meet. So they've left a difficult circumstance. They've endured many difficult circumstances to arrive here, and then things aren't easy when they get here. So I want to kind of paint this out. One way that I think about risk is, you know, it's not necessarily just that each of these sort of add up to more mental health or adjustment problems, but it can actually be an exponential kind of relationship. So we can think about it like, you know, 1 + 1 doesn't necessarily equal 2, but 1 + 1 might equal 5, right? So there can be this real exponential effect of risk. And here's a slide speaking to some of the many impacts that all of these experiences may have on mental health. And it's really important to take a developmental lens. So, you know, what those experiences will look like in young children will vary, will be different from school-age children and adolescents. Excuse me. There was a really interesting report that just came out from detention centers that found that the clinicians who were mandated to do the treatment in detention centers really lacked training in how trauma manifests in young children. So that's a real need in terms of you know, where there's a gap. So we talk about trauma-informed care, but we also really have to have a developmental lens. And I know for those of you in the room, I'm preaching to the choir. So there are a number of important barriers to healthcare for folks who have gone through this pipeline, who have had these traumatic experiences, health literacy being one, coping strategies. A lot of the kids that we've spoken to in our studies, they would never think to ask for help, even with, you know, sleeplessness, nightmares, hypervigilance, a lot of the symptoms that they may be having. You know, a lot of them are Latino men, boys. They really, there's a culture of reliance on self that doesn't have them walking through the door when they first start experiencing these symptoms. And then, of course, all of those political and legal differentiations, there's a lot of issue around trust and privacy, and not surprisingly, if you give someone a piece of paper and ask them to sign it, that's a huge barrier in terms of getting people in the door. There are also specific barriers that are important to think about in terms of mental health care. Again, fears of deportation, not understanding the system, not understanding how a hospital or medical health care system may or may not be related to other systems, immigration enforcement and others. There may also be simple things like a lack of resources for accessing services. And a lot of the kids we spoke to, they talk about their parents not able to get into treatment because, they don't have a way to get there. They don't have bus money, or they're working during the hours where the clinic is open. So sometimes it's as simple as those kind of logistical, practical things that can be a really important barrier. And I'll talk later about how important it is to do work in schools because it really reduces a number of those barriers. So a lot of the kids that we work with in our research here in the Bay Area, we kind of follow the migration patterns with our partnerships and research studies. So there are many, many kids coming from Central America right now. The largest group of asylum seekers of all ages right now are from El Salvador, Guatemala, and Honduras. And it's amazing to look at that increase. So a 329% increase in unaccompanied children between 2017 and 2019. And that's just those who Border Patrol are sort of capturing and recording in terms of documentation. So likely the numbers are much larger. So here we have the percentage. So you can see 37% from Guatemala, El Salvador 28, Honduras 27. So 99% of unaccompanied minors are from Central America. So again, we're really thinking about who are the kids who are arriving across the border without the protection of being part of a family unit or having a parent or guardian with them. And a lot of these kids are resettling in the Bay Area. So once they go through whatever process at the border happens, whether that's detention or processing, which can take a very long time, months, they are resettled. And the Office of Refugee Resettlement, the latest report in 2018, found that the Bay Area was second only to Los Angeles in terms of the numbers of those unaccompanied minors who are being resettled. So this is so important, and I'm sure many of you are seeing this in your practices. There are a lot of kids in the Bay Area who are going to be coming to be our neighbors and be our community members, and who may or may not have a lot of those traumatic events that really deserve clinical attention. So the research in our lab is largely community partnership research. So as I said earlier, we have an idea based on the research literature and thinking about some of those numbers, who's coming and what kinds of traumatic experiences they've had, about what kinds of studies should be done. But also really important to our process is partnering and really asking the communities that we do work with, well, how can we help you? What are your needs? So we've started projects with San Francisco International High School, with Oakland International High School, really just by asking that question. We have some research skills. You have a population who you may like to know a little bit more about. How can we partner and come up with something that's sort of mutually beneficial? So we've really tried to hold to that principle. And you may have seen this model, socioeconomic, ecological model, which really keeps in mind for all of us working with immigrant youth the many sort of nested systems that they're operating within. So we may come into contact with them at the point of school, but their role in school will absolutely be impacted by whatever's going on in other aspects of their microsystem reality, their families, health services, their neighborhood, etc. So I'll start just with this study that we did back in 2010, and this was with a pretty diverse sample, but what I want you to understand from this is that the symptoms that newcomer immigrant youth are reporting are much higher than their teachers are perceiving. So we went in and we asked kids and teachers about all these different range of symptoms: affective, anxiety, somatic, and ADHD. And the gap there shows that the student reports of all these symptoms were significantly higher than the teacher report. And for those of you working with kids in mental health, you know that gap is always the case. There's always some gap between what a child will feel and self-report and what adults in their lives will perceive. But this gap was significantly greater than the gap that we normally see between teachers and kids. And this was in a system of international high schools where the teachers are actually very well trained to understand and be sensitive to the needs of their newcomer students. So it's really important to keep in mind that kids are experiencing a lot of symptoms that we may or may not see. And we've seen this in our more recent studies as well in terms of trying to assess needs and having a hard time having kids report to us and teachers report on symptoms. So the next project I'll speak about was here locally in the Bay Area, and it was one of these partnership projects where we started with a needs assessment because the school said this is what we could use. They had all these newcomer 9th and 10th graders, and they really didn't have a handle. They had maybe one counselor on site. They didn't have a handle on all of the many service needs that their population may or may not have. So legal, dental, mental health, medical, educational, you name it, they really didn't have a handle on that. So they asked us to sit down and interview all of their incoming students. So we did that. That team of doctoral students and I spent quite a bit of time in quite a number of languages having a conversation with these kids and trying to understand a little bit more about their experience and trying to then report to the Wellness Center and help them get tracked into services. So from that project, we ended up using the data and analyzing the qualitative data to understand a little bit more what kinds of risk factors may be most prevalent for these kids. And I'll just share a few of those that weren't necessarily things we knew about in the research literature. The first being educational gaps. So this participant said that he studied until the 8th grade. He had surgery, he went back to finish school, but in his country of El Salvador, there were gangs which prevented him from being in school. He said, they told me to sell drugs, join the gang, or else I could not return to school. So he lost another year. So he lost the 5th and 7th grade. Then he migrated here and enrolled in the 9th grade as an 18-year-old. So this presents a whole number of risk factors and challenges, one being just the gaps in learning, but two, the developmental difference between an 18-year-old and a 14-year-old is pretty big. So this was something that there isn't a whole lot of research literature about and that really stood out from these initial needs assessment interviews as a pattern that we saw with a lot of the kids. A second issue that came up were detention center stays, which is a lot more in our sort of public awareness now. This data was collected several years ago before Trump. But nonetheless, this person said that it felt strange. The experience was really bad. They didn't get food or a brush. They didn't get proper clothing. They kept being moved. So they were moved from shelter to shelter. He was separated from his brother, even though felt like they were in the same place, but they weren't allowed to be together, and he felt really scared. So we heard a lot of these stories of how negative the impact of detention was. And if you think about it, these are kids who have just fled all of those circumstances in their countries of origin, gone through a whole host of traumatic experiences to arrive at the border, and then the first thing they're received with is basically like a prison, with the added dimension of really not knowing what is the system that I'm in, where am I, what's going to happen, how long will it take, will I be here for 3 days or 3 months? So really very traumatic for these kids. And then some of the issues that we heard about after migration that, again, were kind of surprising in a way. We hear a lot about family separation. A lot of the kids in our study, they weren't necessarily, they weren't kids who were forced in terms of separation, but they had these sort of patterns of migration where a parent might come many years prior, and so they had prolonged separation from their parents. And so the reunification ended up being really complex. If you imagine, a parent and child who haven't seen each other for 12 years, and then they're reunited, and instead of being a, cute but challenging toddler, they're a perhaps less cute and more challenging teenager. And so there were a lot of challenges that came up around their reunification. And kids talked about their parents being really kind of impatient with them. Some of the kids we talked to felt like they felt this guilt, like they should have affection and feeling for their parent, but they didn't. So the reunification process came up in this needs assessment project is also very important and impactful. And From this data, I've had one dissertation study come from this where we looked at, because of those issues that came up, the experiences of separation and reunification. We're in the process of coding this and hopefully publishing soon. But we learned a little bit about how long the kids had been here post-migration, a little bit about those patterns of migration. So again, often a parent came first or a sibling came first. And again, we learned a lot about how the reunification was really complex. So while some kids talked about it as a very positive experience, others talked about it as really challenging. They didn't get along, they didn't grow up together. Okay, so then this project led to what we've now just completed, which is a longitudinal study of risk and resilience. So we kind of put together a whole host of factors that we thought were significant, both from the research literature and from these needs assessment interviews that we learned about. And this pink visual on the left speaks to how important it is to engage with your school community or your partner community as you're going through the process of developing a measure. So we started with a survey that we then sort of ran through both the staff and students for feedback, translation processes. We pilot tested it with students, which was really important. We learned a lot about which questions weren't ones that this population was going to understand. A lot of measures, they're really not normed on an English language learning, newcomer, not very computer literate population, right? So we had to make some adjustments to really try to make it accessible for our population. And we translated it into about 7 languages. So that's the broader sample came from those countries. And I'll just talk a little bit about one of the studies that has come from this data so far. We're still in the process of organizing it. But this was a quantitative study that was one of my student, Holly Mueller's dissertation, and she was interested in attachment. And I think, for those of us working with kids and adolescents, having an attachment lens is so important when we work with our kids, and in particular for folks who have experienced all of those separations and perhaps complex reunification. So her hypothesis was whether disruptions in attachment, so attachment styles that were not secure, made the immigrant youth in the study more vulnerable to all of those post-migration stressors. And in particular, she was looking at community violence. So she found that 64% reported insecure attachment styles, so that's much higher than the general population. And she found that among those who had those attachment styles that were less secure, the impact of community violence indeed had a bigger impact on internalizing symptoms. So there are a number of ways we can think about this. One being, again, coming back to that self-reliance. So if you lack a strong attachment relationship, you may be relying more on yourself when dealing with stressors like community violence. It may also be that they lack coping mechanisms to manage community violence. But this is really important for us to think about, because this is an additional layer of risk that isn't in the previous research literature in terms of the many sort of impacts and ramifications that those separations may have. And not just for young kids, but for adolescents as well. So some implications for actions, and I like to think about, not just clinical actions, but what else can we be doing in our work to help improve the lives of immigrant youth and families. So one, we really need more comprehensive services that have a trauma-informed lens, and not only trauma-informed, but also informed by all of the economic, social, legal, and educational needs that these kids are experiencing. So, it's very complex, and we have to have a sense of that broader picture in order to be able to have these kids come through the door for services, and in order for our services to be appropriately tailored to them. In terms of program development, we definitely need more school-based programs. So if you think about all of the barriers to treatment, San Francisco General Hospital is right here, in the heart of the city, and yet all of those barriers can be really significant in terms of getting people through the door. So we have to think about, well, where are immigrant kids? And they are in school for the most part, right? The legal designation does not bar kids from attending school. That was a policy that was passed some years ago. So kids are able to go to school, and it's really an important frontline place for us to access these populations. And then we really need to think about our immigration policies and how we can can evolve those to consider the really complex and psychosocial burden that separations and reunifications are having on immigrant youth and families. So I wanted to leave you all as clinicians on the front lines with some practical strategies for supporting newcomers. So medical, really connecting people with primary care, connecting people with medical providers who are familiar with PTSD, and I think, often, and Nick Nelson speaks really eloquently about this, as a physician working in an environment where a lot of people may be coming in with physical health concerns, and it's really important when you hear that somebody is an immigrant or an asylum seeker to look past the physical and think about, well, are there mental health issues that are going on, or is this a physiological manifestation of PTSD? Socioeconomic concerns, of course, and legal concerns. So those of us operating within the field of mental health, we should absolutely be familiar with and ready to either directly help or refer our patients to help in terms of the legal process. So some next steps. So I've been doing this work for about 15 years, partnering with schools and clinics, and that's my goal for the next 15 years. But I'd really like to do work that is able to deliver services, as we've been talking about, in the settings where services can be delivered. So identifying needs early in the process of asylum seeking is really important, and again, really engaging with schools to deliver services in an effective way is important. So one of the projects that I just submitted a grant for with Alfonso Mercado down in Texas is a partnership with the Humanitarian and Refugee Center in McAllen, Texas. So it's right on the border. And it's a place where right after immigrant and refugee families are released from a detention or holding facility, they have 24 hours in this Humanitarian and Refuge Center before they're basically sent on to their lives. So it's a really important space for understanding needs, delivering services, and helping them with what will then be their trajectory in the United States. So we've submitted a grant to do a needs assessment and try to better understand a little bit more about what their needs are, but also to better understand what the detention center experiences are like. And this is in part because it's really hard for people to have access to do research and clinical services in detention facilities. So here's a space where we might be able to learn a little bit more about what's going on in those facilities. So that's one project I'm excited about. And then the next, which many of you in the room may be familiar with, Will Martinez has a grant to deliver preventive programs in schools, and I'm excited to work with him on that. And the idea is that, again, schools are these front lines places where kids are throughout their day, and the schools are really invested and excited to have services to help their kids do well in school. So we have to, not only think about the mental health outcomes, but academic and other kinds of outcomes that we want kids to have in terms of healthy adaptation and adjustment. So in conclusion, then we'll have some time for discussion and questions. I want us to really keep in mind how policy changes really impact the social context and the lived experiences of immigrant families and children. So not only in terms of the numbers of people coming through the border, like we saw in that first visual slide, but the kinds of fears that kids may or may not have, the safety that their parents may have or may not have to parent them. So we, I guess I just can't underscore enough how important it is for us to think really in a broad way about policy and how that impacts the lives of the kids that we're working with. Similarly, we can't ignore that there are really large numbers of unaccompanied minors coming from Central America who have a lot of psychosocial need, and so we really have to tailor our programs to address the complex trauma that they've experienced. And to do this, partnership work, I think, is so important. So partnering with the clinics that are serving them, with agencies, with schools, and I think, just really having that sort of humility to go in, understanding that we may not have all the answers. We may have few of the answers, but we may have some skills that can help them to serve their population and to understand them better. And just a couple of resources, and I'm happy to share these slides or these last slides with folks. But if you haven't already seen, these are things that can be helpful to give to your patients. So what do you do if ICE comes to your door? How do you talk to kids in your family about deportation? And these are some great resources of organizations and websites that you might look to for further information. So again, thanks to everybody who contributes to this work. And I'd love to hear what you think. And if you have questions, I think we have 5 or 10 minutes maybe. I know you'll have to get somewhere else, but thank you. Questions, comments? Yeah, it's a great question. So in case you're on Zoom and didn't hear, her question was related to working with refugees and where and how we can help undocumented asylum seekers and those who don't already have those legal protections. And I think, you said it in your last part of your question, that I think really the answer is to expand healthcare and access, because, well, both. Yeah, it would be great to help more people have documentation and refugee protection. But as the system currently works, that's a really lengthy process, and it can take months and years and many resources and time. And so I think, we can't wait for people to have those kinds of protections in order to get them into health services. And I think we do need to absolutely increase ways. And some of the things that are important for a population of folks who really fear systems like that are, as I said earlier, not requiring some of the same documentation or processes or doing things to help people feel really safe in seeking healthcare. So I think that is really important to think about who are those broad populations of people who we maybe aren't getting access to, or who aren't accessing treatment because of those legal designations. Yeah. Other questions? Okay. Thank you all for having me.